Hello everyone, this is Megan Leo. I'm going to be talking about cardiac ultrasound now. So I'd say probably two of the most important ultrasound applications for the emergency physician is going to be your FAST and your bedside echo. This is going to help you take care of patients better. You're going to understand why they're sick, and it's going to also save you a lot of time doing other tests and whatnot. So this is a really important application. I feel like a lot of people initially are a bit intimidated by learning cardiac ultrasound or echo, and I want to sort of demystify that for you. Our objectives are going to be to focus in on just really four main clinical questions that are important for us in emergency medicine when taking care of some of these patients that come in for a variety of complaints, whether it be chest pain, whether it be shortness of breath, or whether they're really sick and being resuscitated. We're going to talk about the technique and review the four standard views for cardiac echo, and these are going to be then paired with these four clinical questions to keep things very simple and streamlined as you're first learning how to perform this ultrasound. As we work through those four views, we'll also talk about the different echopathology that we'll see, and then we'll do a nice summary at the end. So our scope of practice is really to look for these four clinical questions. So is there aortic root enlargement? Is there evidence of LV dysfunction? Is there evidence of RV strain? And is there a pericardial effusion? To perform the cardiac echo, we're going to be using our phase array probe. So this is our lower frequency probe that has a small footprint so we can get in between ribs. It's going to allow us to image into the chest and view the heart. Our Spark machine will default to the cardiac preset, but if you're working at another place, you may have to remember when you switch your probe to actually make sure it's on the cardiac preset. And there's four main views to image the heart: the peristernal long, peristernal short, apical four-chamber, and subxiphoid view. And we're going to pair these four views with those four clinical questions to keep things nice and simple. So for the peristernal long axis view, you're going to start with the probe just adjacent to the sternum, the left sternal border. It's about at the third and fourth intercostal space at the level of the nipple. And your marker is going to be down the long axis of the left ventricle, which with our convention, which is the cardiac convention, we start with our marker towards the right shoulder. As we move through the four views, we'll be moving in a clockwise motion. So we start with right shoulder, and then rotate to the left shoulder, and then towards the left. So this is the only time in clinical ultrasound that you'll be pointing the marker actually to the left of the patient, is during this echo exam. Now, with each of these views, you really are aiming for the optimal view. So the positioning of the probe here is just to give you a guideline, and then when you get your view, you want to really adjust the probe to the needed location to get the view that you see below. So this is a nice normal peristernal long axis view. Here's another display of sort of where our probe is on the patient's body and imaging through the heart here in this peristernal long axis. So we're going to be using the peristernal long axis mainly to answer that first clinical question: is there a dilated thoracic aortic root? We'll be doing aortic root measurements. And then we're also going to talk about how the peristernal long axis can be used to estimate global left ventricular ejection fraction, also evaluate for fusions. This view is not very good for looking at the right side of the heart, so we can't really answer too much about whether there's RV strain. So here's a nice normal peristernal long view. I'll just kind of zoom in here, and we can go through all the structures here. So here is your right ventricle. Here's your aortic outlet. These are the valves here. Here is your left ventricle, and then here is your left atrium. And what we're going to be looking at here is the aortic root there. We'll also be focusing on this anterior mitral valve to look for ejection fraction, and then we'll also be looking posteriorly here to look for effusions. So here's an example of a good location to measure the aortic root. You want to do what's called the leading edge technique, which this arrow isn't quite displaying, but you want to be on the outside wall of the near wall, coming through to the inside wall of the far wall. So let me zoom in again here. We're going to be going kind of like to there. So outside wall of the near wall to the inside wall of the far wall. And you want to be at the tips of the valves. So here's the valves here. And measuring just at the tips, but also beyond these coronary sinuses. You can see these little outpouchings here. You want to be just beyond those to get your accurate measurement. So anything less than 4 centimeters is going to be normal. Now here's an example of a pretty obvious thoracic aortic aneurysm. You can see this is hugely dilated. You can use the lines of the M mode to get an idea of how dilated this is. So we'll zoom in here. Each one of these dots here is a centimeter. So I mean this is 1, 2, 3, 4, 5, 6, 7, 8 centimeters. So this is a really bad thoracic aneurysm. So off of the peristernal long axis view, you can also do an assessment of LV ejection fraction. So this is called the E-point septal separation, or EPSS. So if you measure from where the closest that the anterior mitral valve gets to the septum, if it's less than 6, this is going to be a normal EF. If it's greater than 12 millimeters, then that's pretty indicative of a poor EF. So you can see in this view, we'll zoom in here. This person is measured from the tip of this valve up to the septum. So this structure here is your septum, and it's within 6 millimeters. This is a normal EF. So you can also take measurements with the M mode along this axis, and take a measurement there as the motion of the anterior mitral valve comes in relative to the septum. So again, here's that nice normal LVEF. You can see that the mitral valve slaps nicely up against the septum there. And this contrasts greatly to this image, which is a very poor EF. You can see that anterior mitral valve doesn't come close to the septum at all. So again, this is mitral valve, and it really doesn't get near the septum, so it's a pretty poor EF. The last thing we can see off the peristernal long view is pericardial and pleural effusions. So this is showing you both of those, and the reason that the descending aorta there is highlighted is because that's your landmark for discerning whether it's pericardial or pleural effusion. So anything that is above the descending aorta is going to be pericardial effusion, or if it crosses midline across the descending aorta. And then anything at the level or below the descending aorta is going to be pleural effusion. And because we're pointed to the left at this point, or towards the right, I'm sorry, this is going to be a left pleural effusion. Okay, so now we're going to rotate our probe towards the left shoulder to get the peristernal long axis. This is going to give you a cross-section through the left ventricle, and we'll be able to assess for global ejection fraction with this view. So here's another example of on the body where we have our probe and where we're pointing our probe. And then these are the 3 levels of the heart that we're going to be sweeping through. So up near the aorta, down to mitral valve, through the papillary muscles and into the apex to assess all levels of the left ventricle function. So the peristernal short axis is going to be our main view to assess for global EF. That's our second clinical question. And you can also assess for pericardial effusions off this. There is a way to assess for RV strain as well, in which you get a D-shaped septum, or if there's high right-sided pressures, it's going to be flattening out that septum. And this is also the view as you get more advanced that you'd be looking for regional wall motion abnormalities. So here is a display of how we've started off in the peristernal long view, and then the probe is rotated into the peristernal short view. And the reason I show it this way is because the peristernal short view is really best obtained after you get your ideal peristernal long view. If you rotate your image and come off the window a little bit, just go back to your peristernal long view, line it up where you can see the anterior mitral valve nicely, and then rotate your probe to that left shoulder. So for classification of LV function, this is going to be a subjective assessment of LV function. So normal is anywhere above 50% LVEF. This is, again, we're subjectively assessing this. The two extremes are usually the easiest. So a normal is going to be somewhat easy to detect, and then severely depressed is going to be less than 30%. And then the moderately decreased is anywhere between 30 and 50. That's going to take a little bit of practice to be able to eyeball that. And there's been studies that have shown that subjective estimates of EF is comparable to the actual cardiology calculations. So you should feel confident about making these calls. So this is a nice normal ejection fraction in the peristernal short view. You can see how all those walls are coming together nicely. If you were to actually just put a little mark in the middle there and watch all the walls closing around your finger or your point of reference in the middle there, you can see how all those walls are coming in nicely together, and that's a nice normal EF. Now this contrasts quite greatly to this next image, which is a severely depressed EF. So you can see the walls are moving a little bit, but really that chamber size is not moving much. This looks like a pretty struggling heart, pretty sad looking heart, however you want to describe it. Definitely sharp contrast from the last image. Now this view I put in here, and we'll talk about it more in hands-on, but this is a subxiphoid short. So when we talk about the subxiphoid approach in the cardiac imaging, you can rotate your probe to be able to get a short axis view of the LV chamber. This is important to know how to do in our COPD patients whose heart sits very low in the chest. Sometimes it's really difficult to get a peristernal long or a good peristernal short view. So and this is kind of a nice trick to have in your toolbox to be able to really get a sense of what the EF is. All right, so now I also wanted to show you an example of a D-shaped septum. So you can see here, this is a peristernal short view. You can see how that septum in between the RV and the LV is kind of pushed down. There's some high pressures here. I'm going to zoom in on this picture to be able to give you a better idea. So this is LV, this is RV, and then this is your septum here, and it's kind of flattened out so that you get this D shape here. All right, so now we move down to the apical four-chamber view. So now we're still pointed marker towards the left, but we've now slid the probe down to the apex of the heart, just below the nipple. Now we're going to angle the beam. So remember we talked about the beam of the ultrasound is going to come out kind of that way, almost like a flashlight. We want that up towards the patient's right shoulder to get an axis right through the heart there to be able to see all four chambers. Having the patient lay onto their left lateral decubitus often will improve the image. Here's another representation of having the patient onto their left. This is the positioning of the probe, and ideally you want to get a view of all four chambers. This view is going to be best for assessing for equality of the RV to LV, so looking for RV strain. Your normal ratio is 0.6 to 1, but you can just remember 1 to 1. So the RV should always be smaller than the LV, and if it's not, there's some component of RV strain. Now, whether that's acute or chronic, acute being an acute PE, chronic being some underlying pulmonary condition or process that causes higher right-sided pressures. You may also see something called paradoxical septal wall motion. So this is going to be the septum bowing into the left ventricle, also a sign of elevated RV pressures. And then there's a very specific sign called McConnell's sign, which is RV free wall akinesis with apical sparing. We'll show you some examples of that in a second. And then the apical four-chamber view, as you get more advanced, this is going to be the view you'll use for any valvular insufficiency, diastolic dysfunction. Also a variant of this view is the apical five-chamber to assess for VTI and cardiac output. So here's an example of RV strain. You can see that the RV chamber is bigger than the LV. This is probably more of a chronic RV strain. You can see there's a lot of trabeculations here. So just to clarify, this is RV, this is LV, here's your septum. And this RV is definitely bigger if you were to measure these out than the LV. So this is a sign of RV strain. But if you look along the wall in here, there's a lot of trabeculations in that RV, which is probably more of an RV hypertrophy or chronic process. Now the next slide here is an example of McConnell's sign. So you can see that the RV is definitely larger than the LV, plus you're getting some akinesis of that RV lateral wall and apical sparing there. So this, again, tends to be a very specific sign for acute PE. So just to kind of point this out for everybody, this is your apex here. You can see that's still moving quite well. There may be some paradoxical septal motion this way, and then you've got some RV free wall akinesis. I'll let that video play just a little bit more so you can kind of get that in your mind. Again, seeing that apex there is still pretty spared in its function. All right, so now we're moving on to the subxiphoid view, which we still have our marker towards the left, and we're going to slide into the subxiphoid space. So this is similar to the fast position, and here we're going to be imaging through the liver, through the inferior portion of the heart. You want to increase your depth quite a bit because you're going to be imaging pretty deep into the chest, and you may need to adjust the FAR gain to lighten the posterior pericardium. So here's another image of where you'd have your probe and where the beam is projecting through the heart. And the RV, again, is that most anterior chamber with the LV just below it, RA, and the inferior pericardium is the image closest to the screen here. So here's your inferior pericardium, and this is your posterior pericardium. So this is the best view to assess for pericardial effusions. This is why it's part of the FAST assessment. And it also can be used to assess for cardiac activity during resuscitation. So when you're doing your pulse checks, you can stick your probe in the subxiphoid space, also looking for cardiac activity. This was also the view where you could rotate your probe and get your subxiphoid short. Again, a little more advanced application of the subxiphoid view, but a nice thing to learn how to do. So not ideal for assessing for LV function or RV strain, but it can be done. I mean, the subxiphoid sometimes is your only window that you'll have, so you can almost do a complete echo exam off that subxiphoid view. So for pericardial effusions, you want to obtain multiple views. If you think you see a pericardial effusion in the subxiphoid area, that's probably a pretty reliable view. If you think that you may have seen one in the parasternal long view, but you don't see it in the subxiphoid, you incorporate multiple views to sort of make your final assessment. Plus, you also need to consider physiologic free fluid, epicardial fat pads, things like that are very common pitfalls. Pericardial effusions are classified into small, moderate, and large. Small tend to be less than 1 centimeter. They're not circumferential, and you rarely, if ever, will see tamponade physiology off of that. Moderate effusions are 1 to 2 centimeters. Large effusions above 2 centimeters, often circumferential, and that's when you'll start seeing your signs of tamponade. So here's a small pericardial effusion. Again, just in that inferior pericardium is where we're seeing it. You're not seeing it much posteriorly. Here's a moderate effusion, so It might even be edging on large there. So, 1 to 2 centimeters, starting to be circumferential. And then as we get even larger, we're looking at tamponade physiology. So this is a large pericardial effusion. You can see that RV free wall there collapsing in. So again, just to remind ourselves of the anatomy here. So this is the RV here. This is LV. This is aorta. And then here, back here is a pericardial effusion there, as well as anteriorly. And if you look at this RV free wall, as I play this clip again, you'll see how it really bows in diastole there, really collapsing in. So that's a very concerning sign, and tamponade by echo. So this you can communicate to your cardiologist, or as you are preparing for an emergent pericardiocentesis if somebody is crashing. Here's another example of a tamponade. So this is the peristernal short view. And again, you can see that RV free wall is really just collapsing in quite a bit. Here we have our apical four-chamber view. You can see that RA free wall collapsing in. And there's probably some subtle RV free wall as well that's collapsing, but you'll see your RA collapse earlier because those pressures within the RA chamber are less. Okay, so remember the 4 objectives of cardiac ultrasound. We're looking at, is there aortic root enlargement? Is there evidence of LV dysfunction? Is there evidence of RV strain? And is there a pericardial effusion? And we can pair these up with our 4 cardiac views. So keep it simple and work through those 4 views in sequence while trying to answer these 4 clinical questions. So here's the summary of our views. Again, we're starting with peristernal long axis to look at the aortic outlet. We're looking at the peristernal short axis to look for LV dysfunction, apical four-chamber to look for RV strain, and subxiphoid to assess for pericardial effusion. All right, and that's it. Thank you, everybody.